Well, welcome everyone and happy Friday. Thank you so much for joining Myotonic today for the first of what we hope will be many Friday afternoon webinars. I'm Dr. Tanya Stevenson, the CEO of Myotonic, and I want to start by saying first that I hope you and your families are all well and healthy and managing this incredible shift that we have all made over the last couple of months. These are challenging times, but I'm very proud that Myotonic is continuing to invest in research and resources this year. We know the needs of our community haven't ended and changed because of this virus, so Myotonic will not pause our work either. I haven't had the opportunity to meet many of you, so I just want to take a quick minute to introduce myself. I started with the Myotonic team this January and am incredibly honored to be a part of this global movement to provide support and education and to help accelerate research and drug development toward treatment and a cure for myotonic dystrophy. My background is in public health, and I have focused for many years on health equity and chronic diseases, both on the East Coast and the West Coast of the United States, leading nonprofit organizations and large-scale advocacy initiatives. Since I joined this team, I've met phenomenal individuals working to improve DM care and treatment, from our academic and industry partners to families and individuals living with DM, donors who are investing in a brighter future for DM, support group facilitators, volunteers, just so many amazing people. And I can honestly say, I have never worked with a more dedicated or passionate group of people, and I am absolutely thrilled to be here today. I have a couple of reminders before I introduce our speakers. Just as a reminder, the Myotonic Dystrophy Foundation, which is now known as Myotonic, is a 501c3 nonprofit organization founded in 2007 by families with DM seeking support and a cure. Our mission, what we call Care and a Cure, is to enhance the quality of life of people living with myotonic dystrophy and accelerate research focused on finding treatments and a cure. We focus on support and education, research, and advocacy. Just a reminder of the resources and support opportunities that are available now. We have many toolkits and publications on our website. We have increased the number of virtual support groups and Facebook chats that are available. Our calendar of activities is updated, and our digital academy, which has presentations and videos from past conferences and events, is also on our website. And I just want to point out that today's presentation will be posted to our digital academy as soon as it is available, hopefully late this evening or possibly tomorrow. We hope folks will join us every Friday at 12 o'clock Pacific time for the afternoon webinar series. We have quite a few topics right now that we hope people will be interested in. These were determined based on feedback from the community specifically, and as it's updated, you can go directly to the website, which is myotonic.org/Friday-afternoon-webinar-series. A quick plug for next Friday before we get into today. Dr. Nicholas Johnson is going to talk about how common we believe DM is in the United States. At this point, with his new study, we believe it's estimated at 1 in 2,300 people whom are affected, as opposed to what we previously believed was 1 in 8,000. So we hope you can join us next Friday as Dr. Johnson discusses the new study and what it might mean for the future of myotonic dystrophy research. So for today, we are talking about sleep and breathing support for myotonic dystrophy during the COVID-19 pandemic. Today's speakers from Stanford University are Dr. John Day, Dr. Jacinda Sampson, and Dr. Michelle Cow. For any of you who have questions for these speakers, I would encourage you to type the questions into the chat box of GoToWebinar, and Leah will provide them to the speakers at the end, time permitting. So first off, I'll introduce Dr. John Day, who is a professor of neurology, pediatrics, and pathology at Stanford University, where he is the Director of the Division of Neuromuscular Medicine. Dr. Day has more than 30 years of experience diagnosing and caring for patients of all ages with myotonic dystrophy. He has spearheaded efforts to define central nervous system effects of DM, focusing on sleep abnormalities as clinically significant, therapeutically tractable, and objectively quantifiable CNS features in myotonic dystrophy. He also serves on Myotonic's Board of Directors and Scientific Advisory Committee. Dr. Jacinda Sampson is a clinical associate professor at Stanford University Hospitals and Clinics. She's a neuromuscular and neurogenetic specialist who has been caring for patients and families with myotonic dystrophy and other familial neurological disorders for over 12 years. She's actively involved in observational and clinical research in myotonic dystrophy, as well as other neuromuscular and neurogenetic disorders. And Dr. Michelle Cao is a clinical associate professor in the Division of Neuromuscular Medicine and Division of Sleep Medicine at Stanford University School of Medicine. Dr. Cao's clinical expertise includes complex sleep apnea syndromes, advanced modes of positive airway pressure therapy, neuromuscular disease, and home mechanical ventilation. As a member of the Stanford Neuromuscular Interdisciplinary Program, Dr. Cao provides respiratory care for patients with myotonic dystrophy who require home mechanical ventilation support. She sits on several national committees, including the American College of Chest Physicians, Home Mechanical Ventilation, and Neuromuscular Disease Network, where she serves as chair. So, Dr. Day, if you would like to take it away.
So thank you very much, Tanya. It's really great to be here. And I'm excited to talk to the community during this craziest of times regarding COVID-19. One of the things that was talked about was what is the intersection of myotonic dystrophy and COVID-19. And fortunately, I'm not personally aware of anyone with myotonic dystrophy who has had COVID-19 yet. If someone is aware of such a person or is such a person, we'd be very grateful to hear what the experience was specifically like so we can even be more educated. But the one place where we knew myotonic dystrophy and COVID-19 did overlap was with regard to ventilatory function or breathing function. And one of the ways that that manifests itself in myotonic dystrophy is one of the factors that influences or affects sleep. So chronic sleepiness, daytime sleepiness is a very prominent feature of myotonic dystrophy and relates in part to breathing function. And so we thought that was an avenue for us to explore and to talk about. So I'm going to get off stage, as it were, fairly quickly and hand the baton to Dr. Sampson, who has studied elements of sleep and its role as a function of central nervous system, and Dr. Cao, who's a bona fide sleep expert and a breathing specialist pulmonologist who works in our division. But first, I thought I would lay the groundwork for the discussion by reminding people about myotonic dystrophy and how it affects muscles that are playing a role in sleep. So these are my disclosures that I do work with a number of companies in the neuromuscular space, many of which are specifically focused now on myotonic dystrophy. And I did want to mention the fact that while 3 of us from Stanford are here, our Stanford team is much larger and includes many people that are playing a key role in keeping our clinical and clinical research efforts going forward. We have a very large clinical research group that has played an increasing role in developing new approaches to myotonic dystrophy investigation, which we hope are soon going to be leading to novel and definitive treatments. So these are some of the studies that we currently have ongoing in myotonic dystrophy at Stanford, and we welcome new participants, certainly those in the western part of the United States and able to come here easily without difficulty in travel are more than welcome to reach out to us. And we'll try to post this slide again so that you can get our contact information. In terms of my aspects of the talk, I did again want to mention the underlying pathophysiology or underlying causes of myotonic dystrophy and show how this kind of relates in a more specific way to breathing and sleep. As you probably remember, myotonic dystrophy is caused in its type 1 form by an expanded CTG expansion, repeat expansion, that's in a region of a gene, the DMPK gene, that does not actually encode any protein. So it was very confusing how this actually led to such a profound and multifaceted disorder as myotonic dystrophy when it was first discovered in 1992. There was greater insight after the gene and mutation responsible for myotonic dystrophy type 2 was identified about 10 years later, which showed a similar repeat expansion in a different gene on a different chromosome, leading to the idea that it really was the expansion itself that caused an alteration in cell function. And that made sense relative to an earlier study that had shown these stretches of DNA that have expanded get expressed in RNA, an intermediate molecule, and that accumulates in the cells. So these blue dots in this upper right-hand corner of the slide, the large blue dots are the nuclei of the cells, and the little pink dots within the nuclei are those RNA expanded molecules. And so they tend to accumulate, and they can be stained in a very particular way to show that they exist. And it turns out that they significantly alter the function of the cell by just being there. One of the cell types that obviously is most affected in myotonic dystrophy is muscle. And we happen to have one patient we were working with who had undergone muscle biopsies 8 years apart. So these are 2 biopsies from the same person. You can see in the first biopsy of a particular muscle, this is normal muscle. This is very normal looking muscle. Whereas 8 years later, looking at a different muscle, the muscle had significantly deteriorated so that the muscle varies in size from one cell to the next. And you can see maybe these little blue dots inside the cell. Those are the nuclei. In the first biopsy, they're very consistently placed on the very edge of the muscle. Whereas in the second biopsy, when the muscle is abnormal, you can see that they have migrated to the center, which is a sign that the muscle is trying to repair itself. It's not functioning normally, and the cell's nuclei move into the center. One of the interesting things, though, is if we look for those pink dots that I showed you before, they're present in that first biopsy. So they're already there. Even though the muscle structurally is fine, those pink dots are already present, indicating the presence of that expanded RNA. And they're still there in the nuclei in the second biopsy. So that the pink dots alter the function of this muscle, even though it's structurally normal. And that leads to the myotonia. So the altered function of the cell caused by the pink dots causes the stiffness of myotonia. And over time, the presence of those pink dots and the factor of time contribute to the deterioration of the muscle and the damage to the muscle, as evidenced in this lower biopsy. So the muscle is structurally abnormal here and causes weakness, whereas in the top frame, it's functionally abnormal, even though it's structurally normal, and still reflects the myotonia. Those 2 features of stiffness and weakness occur in all the muscles of the body. So they also occur in the muscles of the throat. So that normally people will have some degree of the stiffness, if you have myotonic dystrophy, in the muscles of the throat that can interfere with swallowing or with speech, so that these muscles can be affected by the stiffness, and ultimately they can also be affected by the weakness. The stiffness tends to affect speech and swallowing, but not usually so much breathing, whereas the muscles in the chest and of the diaphragm can be affected, and they, as they get weaker, clearly affect breathing as well. So you can have an alteration in breathing caused by the weakness of these muscles. The muscles in the chest also can have the stiffness of myotonia, and sometimes people will present with stiffness or pain in their chest wall caused by involvement of these muscles. Now, the weakness of the throat becomes much more evident when you're lying down. As you lie down, gravity will tend to pull these muscles, and if they're weak enough, there can be an obstruction, and that can lead to an obstruction in the airway. So that there is a component of weakness here caused by the myotonic dystrophy that can obstruct the airway, and that will become much more affected when you're lying down, and this interferes with the breathing of sleep. Similarly, the muscles of the chest wall and diaphragm are not as effective when you're lying down, so recumbency will itself alter the effectiveness of breathing. And if you start out with weakness of breathing muscles and then lie down, the effectiveness of the breathing gets even that much more marked. And you end up with sleep disordered breathing problems, which become fairly significant and will be part of what's discussed by Dr. Cow as she brings up the final part of this presentation. So that's all I wanted to share today. And what I did then want to pass the baton to Dr. Sampson, who can talk about sleep as a feature of the central nervous system and how it relates in myotonic dystrophy. So why don't I let Dr. Sampson go ahead here, and she can control it from her computer.
Thank you. I'm Jacinda Sampson. I work with the neuromuscular group here at Stanford. And sleep and fatigue are a complex thing in myotonic dystrophy. And we think that it's not only a reflection of the abnormalities in muscle that we just reviewed, but also that of brain. One of the things that we have been appreciating more and more about myotonic dystrophy over time is the experience of people with myotonic dystrophy of their sleep problems and how varied they are. This is some data that we collected using the Alliance Sleep Questionnaire that was developed by the Stanford Sleep Center, just enumerating the different ways that sleep is affected in myotonic dystrophy. You can see for people who have myotonic dystrophy, which we represented in red, that there's relatively few people who will report that they don't have any sleep problems at all, less than 10%. Although sleep problems are also common in people who don't have myotonic dystrophy. You can see over 50% of non-myotonic dystrophy individuals also reported some sleep difficulties. Not everyone has a problem with snoring, but apnea is fairly often observed, which can be mechanistically related to what Dr. Day just described about upper airway obstruction. And Dr. Cow is going to talk about how that can be managed. But daytime sleepiness, over and over, many groups and all of our patients describe this daytime sleepiness and that they don't feel rested when they wake up in the morning. But another interesting thing is that there's also a difficulty in falling asleep and staying asleep, and a great deal of difficulty keeping with a consistent sleep schedule. So you can see that there's lots of different ways myotonic dystrophy can affect your sleep. We found, just as many others have, that if we ask about sleepiness, that sleepiness is very common, both in a moderate amount as well as a severe degree, and that there's also an associated fatigue. And fatigue is such a difficult thing to define. It's not only sleepiness or muscle weakness, it can be cognitive fatigue, it can be decreased endurance, it can be related to mood, such as depression or anxiety. So fatigue is a really complex symptom to study. I think one of the things I was going to focus on today was how common insomnia was in our study with the ASQ, which preceded this whole COVID-19 epidemic. You can see that it's not uncommon in the general population to have some insomnia, but there's also an increased incidence of insomnia in the myotonic dystrophies, both type 1 and type 2, sometimes severe in extent. And now that we are experiencing the COVID epidemic, I think it's much more widespread, although I have no data regarding this, that I think many people are having more difficulty with sleep and anxiety because of all the changes that have been going on in our society and in our personal lives. So what can we do to combat our insomnia? I think one of the things to remember is that our body has a clock. It's not just our sleep system in our brain that regulates this clock, although that's important in your alertness and sleep, but every cell in your body has an internal clock. It has it's called the circadian rhythm. And this regulates many aspects of your body's function, not just wakefulness and sleepiness, but protein synthesis in cells, hormonal secretion, stress responses, and even your immune system are influenced by sleep. So some of the things that you can try to do, which can be very disrupted when you're in a situation of either sheltering in place, or if you're an essential personnel working irregular hours or shift work, is to try to keep a regular pattern to your wake and sleeping. Having light on your eyeballs in the morning helps, tell your brain that this is when to set your clock. Having some degree of exercise or movement during the day, whatever your body allows and keeps you active, also helps with your nighttime sleep. And having your bedroom being dark and quiet and comfortable for sleep is really important. I often use the analogy of sleep as being like a swing set, that it has a pendulum quality on its own, but it needs to be pushed in order to keep its momentum. And the things that push your sleep to stay on a regular schedule are those things like having a schedule, light and dark, and activity, and a consistent bedtime. Some other things that can disrupt this pendulum phenomenon, this circadian rhythm, are things like alcohol. Having stimulants throughout the day, even if caffeine is not keeping you awake, it could, because its metabolites persist for a long time, be interrupting your ability to fall asleep, even if it's not keeping you alert. And strong sedatives can depress your breathing and actually worsen sleep apnea. So certain sedating medications that can affect muscle tone and your brain's natural rhythm of breathing can affect your sleep breathing as well. And I'm going to let Dr. Cow talk about this in her presentation, because she is the expert on it. But if you're supposed to be on non-invasive ventilation, either BiPAP or CPAP, do try to do your best to use it as it's directed. It can be really difficult to get used to non-invasive ventilation, but it can be extremely helpful in improving the quality of your sleep. And I think now more than ever, putting away the screens before bedtime and having a period of winding down before you go to sleep is really helpful in combating insomnia. We talk about blue screens and how the blue screens interrupt our circadian rhythm and that natural sleep cycle. But I think these days it's not only the blueness of the screen, but the content of the screen that perpetuates anxiety and leads your mind to dwell on things and can help interrupt sleep. So I think, respecting your sleep as an essential part of your body's function, that it's necessary in so many different ways for your health, and making it a priority is an important way of staying healthy, just like having a healthy diet and exercise. So I just wanted to spend a minute or two talking about how sleep is a brain function. And one of these things is a study that we did with the Stanford Sleep Center here with Chad Ruoff, looking at brain waves during sleep. So if you've ever had a sleep study, you probably remember having wires placed everywhere, your brain over your heart, on your muscles, a band to sense your breathing, and as well as your pulse, and a microphone to listen to you snore. But one of those, the data that was sampled is this EEG data. And this is not what the raw data of an EEG looks like. This is not the original form of what your brain waves look like. What we did is we processed this data in order to look at the slow brain waves, which are closer to zero, compared to the faster brain waves. And we compared individuals with myotonic dystrophy who are graphed in blue versus the controls, which are graphed in red. And what we found when we looked at these sleep studies, that even though the controls were people who did not have myotonic dystrophy, they still suffered from sleep disorders. They had daytime sleepiness that was just as bad as individuals with myotonic dystrophy. And yet we found differences in the patterns of their brain waves, both when they were awake as well as when they were asleep. And so we think that this is reflecting how the central nervous system is involved in myotonic dystrophy. Another thing that we've been involved in recently is a multi-center study along with the University of Iowa and 2 sleep centers, one in South Florida and one in Bethesda, Maryland, looking at a GABA pathway inhibitor as a potential treatment for daytime sleepiness and fatigue. And so we don't have any data to present today, but the study has completed enrollment. And right now the data is being analyzed, and we hope to be able to present that in the next few months. But the outcome measures, we're looking at subjective sleepiness, as well as maintenance of attention, and as well as the EEG output. And so this will be studied further in phase 2 trials, hopefully in the near future. I can't really give you a good timeline because COVID-19 has disrupted somewhat our clinical trials scheduling and planning sometimes. So I just wanted to emphasize that the involvement of the brain in myotonic dystrophy is an area we're really interested in here at Stanford. If you aren't able to come here in person because you're sheltering in place, or you just live a far way away, we are collecting more ASQ information about how sleep affects you. And we also are interested in any of your family members or friends who can be controls who don't have myotonic dystrophy to participate as well. We're also studying the EEG brainwave changes in myotonic dystrophy during wakefulness to understand this better. And I look forward to when our postdoc, Tahera Kamali, will present her data as well. She has recently had a paper accepted using artificial intelligence or machine learning techniques to look at MRI imaging to define differences between myotonic dystrophy and control populations. And then, as Dr. Day mentioned as well, we are also very interested in using CSF or cerebrospinal fluid as a biological material to find biomarkers for both severity of disease as well as potentially something that could be a response to therapy in future clinical trials. So there's many different ways to participate in research here at Stanford. And I'll sum up with that and then pass the baton to Dr. Cow, who I think will be able to teach us more about how myotonic dystrophy affects breathing, sleep, and the respiratory support.
Hi, my name is Michelle Cowell. I'm a sleep specialist and a pulmonologist at Stanford. And thank you for inviting me to this webinar. And I'm going to take off exactly where Dr. Sampson ended in terms of sleep and breathing in myotonic dystrophy. So let me just minimize this part here. Okay, so in terms of sleep disturbance for myotonic dystrophy, you can see here that Dr. Sampson and Dr. Day spoke about several etiologies. So there is REM sleep dysregulation, which is the deep sleep. There is evidence for central hypersomnia. This is similar to what narcolepsy patients experience. I will focus more on the sleep disorder breathing. And then there's also just movement disorders, periodic limb movements, restless leg that are associated with myotonic that can disrupt sleep. Okay, so some symptoms to watch for in terms of unknown or undiagnosed breathing problems during sleep. So for night symptoms, you can see here that there's frequent, you can have frequent arousals or disrupted sleep. Patients complain of unrefreshed sleep, especially when they wake up in the morning. There's some patients have increased sleep hours. They might be sleeping, 10, 14, 16-hour days. They also have irregular sleep hours, which goes into the circadian rhythm disturbances. These are, sometimes patients sleep at 4 in the morning, wake up at noon, and so forth. And then there's also insomnia, which is what Dr. Sampson mentioned. In terms of daytime symptoms, some patients complain of fatigue and lethargy. Many patients complain of excessive daytime sleepiness, reduced exercise capacity. Depending on your disease severity, you may experience shortness of breath. There's mood changes, and then there's cognitive impairment. I stress so much that breathing impairment always begins with sleep for neuromuscular patients and particularly for myotonic patients. So this is a progression of the impairment that happens. Initially, if you start out, you have normal sleep. What happens with the evidence of neuromuscular respiratory impairments, such as diaphragmatic weakness, is that you develop REM sleep. REM sleep is deep sleep, and this is hypoventilation, which is when you retain carbon dioxide during sleep, and hypoxemia, which is when the oxygen level during sleep is low. And then it progresses to non-REM, which is the lighter stages of sleep, and you have non-REM and REM, hypoventilation and hypoxemia. This will progress to daytime hypoventilation, hypoxemia. So at this stage in the disease process, patients have evidence of CO2 retention during the day, as well as low oxygen levels during the day. And if this leaves untreated or unchecked, patients develop cardiac and pulmonary failure as a result. So what happens with breathing during sleep? This is what happens in normal individuals. It is magnified in myotonic patients, but for a regular person, what happens when you fall asleep is that you have reduced volume of air in your lungs with each breath you take. Your breathing muscles are relatively weaker just because you're sleeping, and the breathing also heavily depends on the diaphragm. And this is where the problem is that in myotonic patients, you have a weakened diaphragm. So if your breathing heavily depends on the diaphragm, then there's a problem there. Even at baseline, when you fall asleep, your blood carbon dioxide level is higher and your oxygen level is lower. The windpipe caliber in your upper airway is also more narrowed. And this is all magnified when you go into deep sleep. And in deep sleep is where the breathing problem is really severe. So this slide, I like to show all of my residents and fellows because I think it really points out a clear picture of what happens with neuromuscular or myotonic patients. So you start out with just having low oxygen and high carbon dioxide during sleep. You don't know about it. It may not be checked. And then if you, what happens is with the disease progression, you may develop symptoms due to this during sleep. And as this disease progresses, you have daytime evidence that you're retaining carbon dioxide, your oxygen level is low, and then you have development of daytime breathing problems. And by here, it's pretty late stage in the game, and you develop frank respiratory failure. So the key here is to intervene early. Early intervention means that you intervene during sleep before it becomes a daytime issue. So myotonic and breathing, right? So we know that breathing is impaired due to the weak diaphragm as well as other breathing muscles. Well, what can we do about it? We monitor the respiratory function periodically, and that's then with your pulmonary function testing every 6 months, 3 months, depending on your clinic. And then we also offer what we call advanced positive airway pressure devices, and this is what you may know as bilevel PAP or BiPAP, including home ventilators. These devices are known as non-invasive ventilation because it uses a mask interface to support breathing during sleep. So we use it at night, but we also use it during the day for particular individuals, depends on the disease process. So NIV, is, as we call it for short, it's NIV. So questions are, when do we start? What type of device do we use? And then for many people will ask, well, what about the sleep study? When do we use the sleep study? So these three questions I can take hours to explain and talk about. But just in general, this is how we evaluate patients when we talk about NIV. The benefits of NIV are many, right? So it's highly effective if used correctly and regularly. It improves sleep quality, improves daytime alertness, energy level, your cognition, definitely improves shortness of breath, and it can delay progression of respiratory muscle weakness. And of course, if you use it effectively, it will delay or prevent tracheostomy. So many of my myotonic patients do ask me about devices. They really like to get into the details of what device do I have, what should I use, how will they function. So in general, these are the devices that are available in the United States, and I broke them into two categories. The first category is called the respiratory assist devices, or RADs for short. These are your bilevel PAP devices, and there are more advanced options. Some of you may have or may be familiar with this terminology, AVAPs or VAPs, which is a pretty advanced BiPAP device. And these are the ones that are in the market. The portable ventilators are the most advanced NIV or PAP devices out there. These are really ventilators, they're respirators, similar to what we use in the intensive care units, but they're for home use. And these are the available ones in the United States. Of course, there are more, but these are the ones that are most commonly used. What about CPAP? So in general, CPAP is contraindicated as it delivers this continuous air pressure during inhalation, exhalation. So you can imagine you're breathing in, you get this continuous pressurized air, which is great because it helps you get more air in. But as you breathe out, you have to breathe out against this continuous airflow, which can increase work of breathing. It can make your diaphragm more fatigued because now you're working harder to breathe out. So in general, CPAP is contraindicated unless you have no evidence of neuromuscular respiratory impairment. Okay, so the topic today, it's a lot of it is about COVID-19. And so I wanted to spend the last few slides talking about COVID-19 in myotonic patients. So COVID-19, as you probably all have heard and know by now, it is a new form of the coronavirus disease due to this novel virus called the SARS-CoV-2. And it causes an acute infection with respiratory symptoms, which is really pneumonia. It is different from the other coronaviruses that can cause seasonal infection in the United States. It is mainly spread by droplets and when you cough or when you sneeze. Now, you do not have to be sick to have symptoms to transmit the virus. And this is the latest scare. I think the problem is that many patients who are asymptomatic and carry the virus, they don't know it because they don't have any symptoms, but they can infect others. The illness can range from mild to severe. So not everyone has severe pneumonia and gets to be admitted to the intensive care unit. There are many patients who have a mild disease and can stay home. The high-risk population are, of course, the elderly patients and those with pre-existing medical illnesses like diabetes, heart or lung disease, and of course, neuromuscular population, including myotonic. These patients are at high risk from dying if they get the infection. So symptoms are similar to your flu, but I would say that 85% of patients will have fevers and cough. As the disease progresses, you can have shortness of breath. And then some people have other symptoms that are more nonspecific, like sore throat, fatigue, myalgias, diarrhea, nasal or cold symptoms, and loss of smell. Now, with the myotonic population, because many patients already have underlying diaphragmatic weakness, you might have a chronic cough and you might be chronically shortness of breath. So what I'm looking for is basically these symptoms that are worse from baseline, right? So that's the key is that your symptoms have worsened from your baseline symptoms. So because it's a pneumonia, COVID-19, myotonic patients who do get infected will require most likely both non-invasive ventilation and oxygen, right? Because it is a pneumonia that needs to be treated. The issues regarding NIV and COVID-19 are problematic, and a lot of people are discussing it. The problem is that non-invasive ventilation, as you know, it is a mask that you wear, and it delivers this pressurized air. So you can imagine that it can increase the spread of viral particles to surroundings and infect others. Okay, this is also the case for cough assist and nebulizer therapy as well. So to reduce the viral spread, most hospitals in the country are going to prohibit use of NIV and airway clearance devices. So if you go to the hospital, they will only use oxygen by the nasal cannula, and in more severe cases, they will go directly to intubation, which is this photo right here when we place that long endotracheal tube down your windpipe, and then we connect it to a respirator or a ventilator. So some things you can do when you're at home. So if you're at home and you have no COVID infection, then use your breathing supports as appropriate as what you do routinely. But your caregivers are going to be your biggest risk, right? Because they're the people that are going to be coming in and out of the house. So they need to follow CDC guidance very closely. Recommend that they wear a face mask, they wash hands, or they use that alcohol-based sanitizer. They don't touch their face. They avoid contact with anyone possibly infected. If you do have COVID exposure or infection, but your breathing has not changed or otherwise you're clinically stable, then you can still stay home, but you need to protect your caregivers, because if your caregivers are afraid of getting infected, then you're going to be in trouble. You want to follow cleaning recommendations for your equipment very closely. You want to monitor your oxygenation if possible. Many people do have a home pulse oximeter, which they can use. And then you want to stay in close contact with your medical providers. So testing for COVID-19, you should notify your medical provider. This is the person that you have the most contact with, whether it's your neurologist, your pulmonologist, even your primary care. If you have symptoms that are new from your baseline symptoms, the key is new symptoms. Depending on where you reside, outpatient testing may be available. So ideally, you would be able to get a test, what I call a drive-through location, which is where you stay in your car, you get your swab, and you go home. This allows you to stay home if you're not severely ill. This allows you to also avoid the emergency room while you wait for the test results. Okay, so what happens if you do have to go to the ER or you get admitted to the hospital for pulmonary care, right? So again, myotonic patients with COVID-19 will require NIV and oxygen. Again, the problem is that you go to the hospital, your home NIV device will not be allowed to be used. So the decision for your respiratory support will depend on how severe your infection is, the hospital policy, of course, and then the physician in charge. So if you have severe pneumonia and you are rapidly deteriorating, that may require intubation and mechanical ventilation support. But if not, if you have pneumonia, but you're not severe, then I think that you need to advocate for use of NIV with oxygen. And depending on where you are, for example, in New York, if hospital ventilators are limited, then they actually may allow you to use your home ventilator. So it depends on where you live. What can you do to advocate for NIV? So this is a topic that are being dispersed widely at many hospitals now. But NIV devices, whether it's a home NIV or a hospital NIV device, it can be modified to minimize viral particle spread. This is some of the things that we recommend. So you have to change your NIV device to a certain degree. So the first thing is that for your mask, you have to use a non-vented mask. But what that means is that all the outpatient masks have those little holes that blow out CO2 as you breathe out. So non-vented masks will not have those holes. So it's called a closed system. And it has to be well fitted, a full face mask, meaning that it has to cover the nose and the mouth. And there's also this mask called a helmet mask, which covers the entire face. You have to add a viral filter, a high quality viral filter. Those HEPA filters in your devices are considered viral filters. You have to have a CO2 exhalation valve. Since you just took away the mask, those little holes in your mask that are exhaling CO2, you have to add an extra valve somewhere in the system. And then your humidifier that's attached to your device or integrated to your device needs to be turned off, because otherwise the humidifier can make the filter wet, and once it's wet, it's basically unusable. Okay, so that's how you can modify your device. Now, alternatively, if you have a ventilator, some ventilators can do a double limb circuit. Now, that's a technical term, but basically, it's basically one tube that goes from the ventilator to you, and then when you breathe out, it goes to a second tube back to the ventilator with a viral filter there, right? So it's a separate closed system, but that's an option with certain ventilators. So it is really key that you work with your durable medical equipment provider and or the hospital team wherever you're at, as the policies are different with the companies, the hospitals, depending where you live. But these are the things that I recommend that you advocate for. And if you contact your pulmonologist, your neurologist, hopefully they can help you with this. So just some photos of what I'm talking about, right? So here's a non-vented mask. It just looks like a full face mask, but it is non-vented, it doesn't have those holes. This is a viral filter. This is, yeah, that CO2 exhalation port. You can see here that little hole. And this is that tubing that you're all familiar with if you use any of these devices. The humidifier moisture exchange is a special kind of like on-the-go humidifier because you can't use your humidifier on the device. So you can add this to help increase the moisture a little bit. So this is some photos of what it looks like for ventilators. So if this is an Astral ventilator, you can see that this is a double limb circuit, what I was talking about, where one tubing will go to you so it delivers that air to you, you breathe out and it goes to the other tubing. So it's a closed system, and these are the filters here. So it filters out the viral particle, and it's a closed system as much as possible without getting intubated. This is another type here. This is the Evo from Philips. It's a double limb circuit. And this is the single limb. So if you have like a BiPAP machine, you could do this, right? So you get one limb. So this is that full face mask that's non-vented. And here's that little viral filter plus the CO2 exhalation port. This is how you would set up your equipment. Obviously, you can't do this by yourself. So your DME company or the hospital employees, the respiratory therapists will have to do this depending on what the policies are. And some resources can be found on many websites now. So American Thoracic Society, CHEST, British Thoracic Society, American Academy of Sleep Medicine, they all have COVID-19 websites on the use of these special circuits. And so I think that's all I have.
Okay, I'm going to open it up to some questions. We have a few questions that came in through the course of the webinar. So Doctors Day and Sampson, and if you'd like to unmute yourself, I will go ahead and ask the first question. There was two questions that came in about sleep position. The first is, does sleep position affect sleep? The second is there a sleep position that is better than another on back versus side, etc.? I sleep slightly elevated for reflux.
So in terms of positioning for sleep, I always recommend sleeping with the head of bed elevated. Usually around 30 degrees would be good. So that helps with breathing as well as reflux. Sleeping on your back in a supine position is probably the worst case scenario because the diaphragm doesn't work as well. So the ventilation is not as good. On top of that, there's also the upper airway, which is the windpipe, and your tongue. So gravity can actually, pull the tongue backwards and close up your windpipe. So there's multiple reasons why sleeping on your back flat is not a good idea. So if you can, always try to sleep with the head of bed elevated.
Okay, thank you so much. I'll ask the next question. If I get sick or I think I might be sick with the coronavirus, what should I do? I saw there were pulmonary care recommendations for COVID-19 and DM, but what do they really mean? What is the most important thing for me to know if I have to go to the hospital?
If you have symptoms that are new than your baseline, let's say you have new fevers and your shortness of breath has increased compared to baseline, you have a pulse oximeter and you check it and your SpO2 is lower than what you usually get, I would definitely contact your medical provider, whether that's your neurologist, your pulmonologist, your primary care. Hopefully, wherever you are, they have the means to order a test, and there are drive-through locations where you can basically stay in your car, go there, get the swab, and go home and isolate yourself until you get the test results back. Now that, of course, depends on how fast the results can come back, and it depends on where you are. Again, it can range from 24 hours to 5 days. Also, if you're not, again, if you're not that sick and you can stay home, then it's always better to stay home and isolate yourself. Now, if you are really sick and you have to be evaluated, then you have no choice but to go to the emergency room. And when you get to the emergency room, you want to tell your ER physician that you have myotonic, that you have a breathing device. It's important to know which device you have, what the settings you have, and what kind of mask you use. So all this equipment is helpful if you can just maybe keep a list of it and give that to your ER physician, so at least he or she knows what they need to do for you. And what I would hope is that if your pneumonia, if you do have COVID-19, and your pneumonia is not severe, then I hope that they will allow you to use your device or the hospital's device in an isolation room until you're better. The other thing that also helps is depending on the ER, but the faster that test comes back, the better it is, right? So if the test comes back in 30 minutes, then they can rule out COVID-19. If the test comes back in 5 days, then you'll be in isolation, and that's when you really hope that you can use your device. So it comes down to basically where you are, the hospital policy, how comfortable your ER physician is, and how familiar they are with these devices. But it's always, always helpful to have that list of what you use and make sure that your neurologist, your pulmonologist is there advocating for you. So
I would also add, you can use your smartphone for this. So most phones have a health app. You not only put in your allergies and your medications there, and the fact that you have myotonic dystrophy, you can include the webpage for myotonic.org, but please put the settings and type of non-invasive ventilation that you use in there. So those settings are handy as a reference for the team if they were to need it if you go into the hospital.
Right. And if you have your own device, I mean, you can actually take your own devices. You may not be able to use it, but at least they can see it and they know what mask you're using, what kind of device you're using, so it helps them.
Okay. We had a question that came in. If you are hospitalized due to DM, oftentimes there are a lot of doctors that are not familiar with this disease. Can you tell us more about who you should be talking to, which type of doctors in the hospital?
So I think that the most important thing is to have a doctor who really is discussing things with you. I think you're absolutely right that a number of practitioners do not have much experience with myotonic dystrophy, and if you have someone who's open and interested and able to learn, then that works very well. And then you can take advantage of the website at myotonic.org. There's a significant amount of very useful information there for a number of the medical issues that are common to myotonic dystrophy.
You can also, if you're admitted to the hospital, ask them to contact whoever's the captain of your care team, whether that's your neuromuscular doc or your pulmonary physician, if they have particular questions about your care. It's always better for us to speak directly to the physician than for you or a family member to have to be the middleman in transmitting information. So I would, recommend that if there's something that you aren't getting your questions answered, doesn't feel right, and you want them to be in touch with your care team, is to try to set that conversation up directly so you're not the middle person.
Yeah, and you don't always get to go to the hospital that your doctors are at, right? So, for example, if my Stanford patients end up at a different hospital, at least I tell my patients that, the doctors from the other hospital can always contact the Stanford, transfer center, Stanford operator, and get in touch with me. So that's something that I would definitely advise, or at least push your doctors to do.
Great. Another question came in. Are there any home CO2 devices that someone can use to check their levels?
Unfortunately, no. So there's, of course, many pulse oximetry devices out there that you can use, but so far the technology is not there for home CO2 monitoring. Now, we can order that test specifically through a DME company, but it is a one-night use, and it is something that it is not for consumer use. It's for professional use.
Thank you. One other question. I have a problem with dry mouth with my BiPAP. Do you have any suggestions?
Sure. There are some technical aspects of that. So dry mouth, first thing I'm going to ask is what kind of mask you're using, right? So if you use a non-full face mask, in other words, like the pillows mask or the nasal mask, you're going to have some dry mouth because your mouth actually naturally drops open. Your jaw drops open naturally when you're in sleep, especially in deep sleep, REM sleep. So normally you're breathing, but if now you've got this PAP machine that's blowing air into your windpipe, which is kind of like a fan in your mouth, so it's going to dry it out. So without a full face mask, you're going to have a dry mouth. The second question is, what kind of humidifier system are you using? So depending on the device, you can manipulate that. The ventilators have a separate humidifier that's attached, and it doesn't have as many options for control. But the respiratory assist devices like your bilevel PAPs, your AVAPs, and so forth, it has an integrated humidifier, and you can actually change certain levels so that you can maximize humidity. So it really depends on how it's set up for you, and do you know how to operate that. But it is something that is something that the patient operates in the home. So it is possible.
Okay, I think we have time for, probably we're at the end. One quick question that came in is somebody's wondering, is someone with DM more likely to oversleep? Is this something that's common in the disease?
It's hard it depends on what's meant by oversleep. A lot of patients with myotonic dystrophy sleep a large amount of time, but still do not feel well rested. And it comes back to the general concept that the quality of their sleep might not be all that good, and so they inevitably sleep longer periods of time. So it's common to sleep a lot with myotonic dystrophy.
Also, an individual's sleep requirement may vary. Some people require more sleep than others, so it might not be oversleeping. It might be what physiologically is more appropriate for them.
Okay, well, thank you so much to all of our speakers.
Thank you.
Thank you.
Okay, thank you.
Thank you,
Bye.
everyone.
Stay safe.